Deputy Vice Chancellor, Research, Innovation and Strategic Partnerships, Registrar, University Librarian, Provost of the College of Medicine, Dean, Faculty of Clinical Sciences, Deans of other faculties, the postgraduate school and of students, Directors of institutes and centers, His Excellency Governor of Ondo State, His Excellency Deputy Governor of Oyo State, distinguished guests, ladies and gentlemen. The 445th University of Ibadan Inaugural Lecture will be delivered by Professor Alonge of the Department of Surgery on behalf of the Faculty of Clinical Sciences. Born on 16th March 1959 into the Alonge family of Okia Oka in Ondo State. His father was a committed teacher whose teaching career took him to various schools in the whole Western region. And his mother, Madam Aino Dorcas Rotibi of Ijesha Ishu Ekiti, was a businesswoman. He began his primary education at St. David's Primary School in Okia Oka, and later the Catholic School in Eba Street at Jegule, Lagos. He started his secondary education at the African Church Grammar School, Oka Abuko, in 1971, but completed it at Owo High School, Owo, where he graduated in Division 1 in 1975. Worked briefly as a laboratory attendant between 1976 and 1977 with the revered Father Foley, whose laboratory chemistry department was the pre-employment crucible of the department at the time. Thereafter, he gained admission to the University of Ibadan to study for an MBBS degree in the 1977-1978 academic session, which he completed in June 1983, winning the Blair Aitken Prize in General Surgery in his final year. He was subsequently appointed the House Officer at the UCH Ibadan on merit in July 1983. He served in the NYSC scheme as a youth court doctor at the Rural Comprehensive Health Center in Oguna, Exako, in the whole Bende State, and won the Bende State NYSC Award for the 1984-1985 batch. Thereafter, he was admitted into the residency training program in surgery in January 1987 and was promoted senior registrar in April 1990 after passing the Part 1 examination of the West African College of Surgeons examination at the first attempt. The then Dr. Alonge proceeded to the United Kingdom to train as an orthopedic and trauma surgeon under the Overseas Doctors Training Scheme in April 1990. On his first posting at Peterborough District Hospital, and at the first attempt, he passed the final fellowship of the Royal College of Surgeons of Edinburgh in April 1991. He secured placement in the Northern Region Registrar Rotation in Orthopedics and Trauma from 1992 to 1995, and passed the final fellowship of the West African College of Surgeon examination in Orthopedic and Trauma in April 1994, and won the Best Registrar Award in the Orthopedic and Trauma Training Program of the Northern Region in November 1994. He later obtained the Doctor of Medicine degree of the University of Leicester, United Kingdom in 2000. He joined the services of the Department of Surgery of this university as Lecturer 1 in Orthopedic and Trauma Surgery on 15th August 1995, and the following month, he was appointed Honorary Consultant in the same field to the University College Hospital, Ibadan. He was promoted to the grade of Senior Lecturer on 1st October 1999 and Professor with effect from 1st October 2005 thereby becoming the first professor of orthopedic and trauma surgery in this university. Professor Alonge has over 110 academic publications in peer-reviewed national and international journals. He has contributed to chapters in books, co-authored books, and authored the Basic Trauma Care, a pocket-sized textbook for emergency medical services. He has supervised the training of 20 fellows of the West African College of Surgeons in orthopedic and trauma surgery since 1995. Co-supervised the Master of Science students as well as 3 PhD students and 1 Doctor of Medicine. Within this university, Professor Alonge has served in several capacities. As Subdean undergraduate in the Faculty of Clinical Sciences and Dentistry from 1999 to 2000. Subdean postgraduate in the Faculty of Clinical Sciences from 2002 to 2004. Member of various committees of the postgraduate school of this university. And he was for many years an active member of the ceremonials committee of this university until his appointment as CMD UCH in 2011. Outside the university, Professor Alonge was admitted to the prestigious AO alumnus in Davos, Switzerland in 1992, and on his return to Nigeria in 1995, he popularized the concept of open reduction and internal fixation of fractures using the AO technique. In addition, he introduced the Belfast technique in the management of chronic osteomyelitis, and this led him to formulate a form of ketriazole antibiotic bead. To complement this formulation, he designed the Alonge Whale Interoperative Antibiotic Bead Maker as a point of technique. He has been the 7th substantive Chief Medical Director of the University College Hospital Ibadan with effect from 1st of March 2011. Professor Alonge was a recipient of several awards and grants, such as the first British Association for Surgery of the Knee, Johnson & Johnson Knee Fellowship to study osteophyte biology in 1997, the Leicestershire Johnson & Johnson Knee Fellowship for the 1998-1999 edition to complete his research work at the University of Leicester on the evaluation of the suitability of the peri-articular osteophyte for the repair of articular cartilage defects. University of Ibadan Senate Research Grant in 1996 and 2001, the John D. and Catherine MacArthur Grant in 2003, and the University of Ibadan Advancement Center Research Grant in 2010. He is a member of many learned societies, including the Nigerian Medical Association, the Medical and Dental Consultants Association of Nigeria, the Nigerian Orthopedic Association, the Osteoarthritis Research Society International, the African Society for Aging Research and Development, and a fellow of the Public Administration of Nigeria. Professor T.O. Alonge is a pastor in the World Alive Ministries International, and he is married to Mrs. Temitope Oluwatoyin Alonge, and the marriage is blessed with children. I now call on Professor Alonge to deliver his lecture titled Arrest the First Leg of the Quartet, Bone Infarction or Bone Infection. Professor Alonge.
Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research Innovation and Strategic Partnerships, the Registrar of the University, Librarian, Provost of the College of Medicine, Dean of the Faculty of Clinical Sciences, the Dean of the Postgraduate School, Deans of other faculties and students, Directors of institutes, distinguished ladies and gentlemen. The sights and sounds of Ajigule City, AJ City as it was formerly called, in the late 60s and early 70s, and probably to date is a grossly misunderstood, sprawling slum, and the stigmatization that is still bestowed on AJ is probably unfounded. In the late 60s and during the Nigerian Civil War, AJ was the city where dog ate dog. Violence was rife, hard drugs were commonplace, and the accompanying vices like alcohol abuse and promiscuity were not in short supply. It was a land where the strongest was the best and held sway on decisions and issues concerning the communities. Ironically, it was in this city, dealing with these bizarre settings, that my passion for the empathetic profession of medicine was born. The momentous two-day journey from Ekrim in Akoko South, local government area of Ondo State, to Ajigule City, Lagos in 1968, tucked in the second-class compartment of the Mercedes 911 truck, was to herald the beginning of my tortuous but exciting journey and exploits in the medical arena. I was promptly enrolled into primary 4 at the Catholic school on Imbat Street, and after repeated torture by the street gangs and irregular lashes of the cane on my well-shaped head, God divinely saved me from the misery by opening my brain to assimilate, and within 1 year I began to speak both pidgin and supposedly proper English. The kind-heartedness and unrelenting efforts of my late uncle and his wife, Mr. and Mrs. Titus of Ibadan, paid off at last. During one of my character-molding outings with my uncle, he requested my company to visit his friend who was involved in a motorcycle crash and was being managed at the Araromi Maternity Center near Alonge. It was during this unscheduled visit that I had a strange encounter that God orchestrated to change my life. In the busy, rather noisy waiting hall, I saw a man dressed in a white overall, attending to the injured victims, including my uncle's friend. My silence was audible, and my uncle, who noticed that I fixed my gaze on this man in white, retorted, "What is the matter with you?" To which I replied, "What is the name of this man in white?" His reply was sharp, "He is a doctor," which I read to mean that his name was Doctor. After a few minutes of silence, admiring this unusual character, in a land where violence and unruly behavior was the order of the day, I could no longer hold my thoughts, and I spoke up. "I want to be a doctor." With a rather pleasant but demanding look on his face, he said, "You have to be very good in school, and you must study your science subjects in secondary school and come out tops." After a long pause, I made a promise. I will do my best. And that encounter, at the age of 10 years, became my reference even at my moment of despair. It is indeed a great pleasure and privilege to present the 445th inaugural lecture and the 19th in the series for the 2017-2018 academic session of our prestigious institution, and delightfully from the Department of Surgery on behalf of the Faculty of Clinical Sciences. In addition, and with a great sense of humility, this is the first inaugural lecture from the Division of Orthopedic and Trauma of the Department of Surgery, College of Medicine of the University of Ibadan. Although I graduated in grade 1, I secured admission to the University of Ibadan Medical School at the third attempt, since the earlier offers for admission to study science will have completed my Ajigule dream of being a doctor. This was the first leg of my doctoral quartet. Mr. Vice Chancellor, it was the bold and courageous Professor O.G. Adao who stood up to administrative harassment, and before then, it was obvious to me that having graduated MBBS, I needed to do postgraduate studies, and on securing my appointment as a house officer on merit, this was a quick pointer to the fact that I was towing the path that would lead to living out my dreams within a few weeks of bloodletting, clapping, and chasing results of investigations It was obvious that the road to becoming an empathetic and compassionate doctor was very long. It was, however, the bold and courageous Professor Oji Ajawa I taught who stood up to administrative harassment, refusing to be intimidated as he signed me up, along with at least 9 other senior registrars, to undertake postgraduate training in England with an unrepentant belief, which he expressed by stating unequivocally, if you guys choose to come back to Nigeria after your training in England, I know that Nigeria will be a better place. But peradventure you choose to stay back, it will still be a blessing to the community you serve. Professor Oji Ajawa, 1990. This was the second leg of my doctoral quartet completed. 9 years after graduation and 1 year after becoming a fellow of the Royal College of Students of Edinburgh, the reality of my calling and passion stared me in the face. As a registrar in the Northern Region of Orthopedic and Trauma Rotation in England, my group rotation took me through 6 hospitals, 2 of which were teaching hospitals, the Royal Victoria Infirmary on the Spring, and the Freeman Hospital. The workload and pattern of clinical cases were fairly routine in most of the postings, save for some super specialty training like pediatric surgery, tumor surgery, L-point shoulder replacement surgeries, in addition to the routine fracture management and arthroplasties of the knees and hips. It was during one of my calls in the emergency department of the South Tyneside Hospital in Stockton-on-Tees, one fateful Sunday morning, that a young black man, known to be suffering from sickle cell anemia, presented with bone pain crisis. Although he could not localize the pain in his lower limbs, a working diagnosis of bone pain crisis was made. Please help me. This pain is killing me, he yelled. To my horror, and just as the young man was narrating the story predicting his crisis, the casualty officer had gone ahead to prescribe morphine and injections along with antibiotics. I could not see the empathy in actions of my white colleague, but I clearly saw a blatant attempt to populate the list of hard drug users by yet another black man. Mr. Vice Chancellor, bone pain crisis in this young man, which presumably was genuine, could be one of 2 things: bone infarction due to vascular occlusion, as you can see on the left side of the slide, or bone infection due to bacterial invasion of the bone marrow, as you can see on the right. The presentation of both clinical conditions may be similar at the onset, but the treatment modalities are distinctly different, and instituting the wrong modality of care would be tagged an inappropriate treatment with grave consequences, particularly when bone infection or osteomyelitis is mixed. In 1995, I returned to Nigeria to serve. I was appointed lecturer 1 in the Department of Surgery, and later honorary consultant orthopedic and trauma surgeon to the University College Hospital, Ibadan, and still in the Department of Surgery. This completed the 3rd leg of my doctoral quartet. In living out my dreams, I wanted to be a doctor, and with profuse encouragement and timeliness from the drivers of the bus of my academic pursuits at various bus stops of my life, to be the doctor, Professor Latif Akoni-Hussein's terminology, and later the surgeon, his terminology. I have worked on methods of identifying and managing acute and chronic bone infections for 2 decades. In the last decade, I've embarked on seeking ways of differentiating acute bone pain due to bacterial infection from bone pain following ischemia occlusion of the osseous vessels in people living with sickle cell anemia. Mr. Vice Chancellor, the 4 legs of the doctoral quartet of my medical journey was a dreaded bone disease called osteomyelitis, a terminology that was coined by Nell Latin in 1854 and was first used in the New Latin Dictionary in 1854. Sometimes abbreviated as OM, the word osteomyelitis is derived from Greek words, osteon referring to bone, myelo referring to the bone marrow, and itis referring to inflammation. However, in proper perspective, therefore, acute osteomyelitis is an infectious, usually painful inflammatory disease of bone, often of bacterial origin, that may result in the death of the bone tissue. Traditionally, osteomyelitis can be classified on account of the length of time the infection has been present. It can be classified on account of the mode of presentation. It can be classified on account of where the infection has originated. It can be classified on account of the causative organisms. And finally, it can be classified on account of the source of offending organisms relative to the bone, exogenous from outside or endogenous from inside. However, for the academic community in orthopedics, the academic telescope of OM classification began in 1938. Troetta classified it according to the vascular architecture. We have the Wolfgang classification in 1970, Kelly's classification in 1975, Zenimada classification of 1984, and Bopper's classification. However, my first orthopedic son, who is a professor of orthopedics today, Professor Shola Guru, who is in the audience, also did a classification of repute. The classic report of 202 cases managed by J. Truter at the Northfield Orthopedic Center in Oxford in 2 decades, 1930 to 1950, during the post-antibiotic era, clearly described 3 age types of acute osteomyelitis. He attributed these age type changes to the changing vascular arrangement at the metaphyseal epiphyseal region, which was shown to be specific for each age group. In infant, they discovered that the blood vessels actually traverse the growth plate and gets into the epiphyseal plate. Therefore, acute osteomyelitis in infancy can actually lead to joint destruction because of the vessels involved. In childhood, the blood vessels are truncated at the metaphysis and they hardly progress beyond that. However, in old age, the growth plate has ceased to exist and the blood vessels can also go through to the joint. This vascular arrangement, premised on Bobo's report of 1921, still stands the test of time today. The controversies, however, surrounding the classification and types of acute osteomyelitis and the complex vascular network in bones clearly tells me and other researchers that osteomyelitis is a complex myriad of diseases that cannot be explained away by a simple definition. In reality, there are no distinct subtypes or classes of this ubiquitous disease. Instead, osteomyelitis is characterized by a spectrum of pathological features which are a reflection of the type and severity of the virulent organism that is causing it, a reflection of the vascular integrity of the affected bone, a reflection of the immune status of the sufferer, a reflection of the microenvironment of the bone, and other systemic predisposing factors. What are the sources of the microorganisms causing osteomyelitis? There is no controversy, however, regarding the sources. It could come via the bloodstream, where it is prescribed as hematogenous. It can come via a contiguous infected focus or foci, and it can also come through inoculation of the affected bone from external sources, which we do by open reduction internal fixation or follow implant surgeries. There is no controversy, however, about the progression of osteomyelitis. Despite the unending debate surrounding the classification and types of osteomyelitis, there is a general consensus about the progression of acute osteomyelitis. Inoculation of the microorganism into the bone from a hematogenous route or route, if you're American, contiguous infected foci, or from surgery, or from open fracture, initiates this dreaded disease. Once the bone infection sets in, leukocytes migrate into the infected area, and in their attempt to engulf the infected microorganisms, the leukocytes release enzymes that lyse the bone. The liquefied tissue comprising of the lysed bone tissue and microorganisms constitute the murky, brownish fluid. However, bone, being a hard connective tissue, is relatively not elastic and does not give room for expansion. The pressure buildup causes the severe pain experienced in acute hematogenous osteomyelitis when the murky brownish slug is still contained within the bone. This is a sharp contrast to the bone changes in acute bone infarction because of occlusion of the arterial flow in patients who have sickle cell anemia. The resulting bone edema and pus from lysed bone tissue spread around and along the course of blood vessels in the bone, further impairing blood flow in the blood vessels, which in turn provides a tracking route along which the pus migrates to the subperiosteal region, giving rise to the cholesterol abscesses. These cholesterol abscesses are often palpable and can easily be picked with ultrasonography if the affected bone is superficial enough. Increased intraosseous pressure, increased intraosseous edema, devascularization of bone segment, and aggregation of dead bone cells, which can cause pathological fracture, often lead to an area of the ventalized bone known as sequestra. The formation of sequestra, along with the rupturing of cholesterol abscesses, leading to the discharge of pus from the bone through the skin, and this, among other features, form the basis for the diagnosis of chronic osteomyelitis, commonly adjudged by some of my colleagues as chronic infection, but which I believe strongly is an aftermath of chronic bone ischemia. The picture depicts a sequestrum that I extracted from proximal humerus of a tendon in chemistry. As part of the inherent response of the human body to contain the spread of inflammation from the bone marrow transversing the cambium layer of the periosteum, a new bone envelope is formed around the sequestra, known as the envelope. These features, that is the formation of sequestra, the discharge of pus from the bone, valve, breakage, and formation of involucrum and pathopneumonic of chronic osteomyelitis. This is the fourth and final leg of the quartet of osteomyelitis. Mr. Vice Chancellor, on arrival in 1995 from my medical missionary journey, I was greeted weekly in the surgical outpatient clinic of the University College Hospital Ibadan by at least 3 patients with chronic osteomyelitis on a weekly basis. The number of patients began to increase by word of mouth when they got to know that there was hope for cure, and with my shameless resolve to tackle this debilitating disease, I decided to carry on working for a solution. The misery written all over the patients, who could easily be located by the pulse trail that they leave behind, got me bewildered, and I came down from my high horses to address local orthopedic issues, whilst not discountenancing my skills in hip and knee arthroplasty surgeries, knee arthroscopy, meniscal repairs, trauma care, and general orthopedic practice. I began my quest by isolating the microorganisms from the discharging sinuses in chronic osteomyelitis, with a view to ascertaining the choice of antibiotics after surgical excision, thereby correcting the mindset of the use of best guess antibiotic prior to and after surgical excision of the infected bone using the Belfast technique, which I introduced into Nigeria in 1995. Our findings was instructive in that the conventional commercial over-the-counter antibiotic being implanted in infected bone cavities in Europe was Septopal, or gentamicin impregnated polymethyl methacrylate antibiotic beads, which was sold for £250 sterling for a pack of 30 beads. The cost of a pack of Septopal beads was £100 sterling more than my salary and allowances put together as a lecturer and also honorary consultant in orthopedic and trauma surgery. Therefore, I wonder how many patients will afford this particular antibiotic bead. What is more, our findings on the antibiotic sensitivity pattern of the microbial isolate from chronic osteomyelitis in Ibadan did not support the use of gentamicin impregnated polymethyl methacrylate antibiotic B, as most of the microorganisms isolated, over 75% of them were not sensitive to gentamicin, but they were sensitive to a third generation cephalosporin called ketrazole, because only 20% were sensitive to gentamicin. Therefore, armed with this finding, I began to source for the supply of ketrazole impregnated polymethyl methacrylate antibiotic beads, and this practice search took me back to the United Kingdom, where I had trained as an orthopedic surgeon. Mr. Vice Chancellor, this academic exercise was not to be truncated as I divinely plunged into the formulation of ceftriaxone PMMA bead using 2 grams of ceftriaxone antibiotic powder and 40 grams of plain polymethyl methacrylate bone cement. The antibiotic powder was mixed thoroughly with the polymer of the PMMA before the addition of the polymethyl methacrylate monomer, which is the liquid. The mixture was stirred into a paste and rounded up into beads and threaded on a stainless steel wire to make the beads. When the beads were fully set within 5 to 10 minutes, individual beads were snapped off the string and placed in the microbiology plates of pure cultures of the commonest microorganisms isolated, Staphylococcus aureus, strep, and E. coli. The plates were incubated at 37 degrees centigrade for 48 hours, after which the petri dishes were examined for evidence of zones of inhibition, or what I describe as peribidial lysis. Extensive peribidial lysis or zones of inhibition were clearly demonstrated in the pure culture plates, indicating the elution of this antibiotic, that is ceftriaxone, from the beads to destroy the microorganisms. This discovery in 1996 was to revolutionize the management of chronic osteomyelitis in Nigeria using the Belfast technique. production of the ceftriaxone impregnated polymethametacrylate bead by threading the paste on stainless steel wires before allowing the composite to set was cumbersome and time-consuming. This led me to design and produce the Alonge whale intraoperative antibiotic bead maker. This bead maker, therefore, allows us to produce 80 beads at 1 minute. This simple point of technique limits wastage of ceftriaxone impregnated polymethametacrylate antibiotic beads. However, despite the pooling of resources and sharing of the ceftriaxone impregnated polymethametacrylate bead produced, remnant beads were still commonplace among most cavities because most cavities will accommodate not more than 40 beads at a time. Since the septopad beads were procured off the shelf, and in an effort to utilize the excess ceftriaxone beads, I set out to evaluate the shelf life and activity of this new antibiotic bead formulation at tropical room temperature when the beads were left dry, and when they were wet, they were stored in phosphate buffered saline, a liquid that mimics the normal body fluid. The findings were simply gratifying, as the dry antibiotic beads continue to elute antibiotics, evidenced by pyramidal lysis or zones of inhibition when the beads were incubated in pure cultures of the microbial isolate up to 12 calendar months. These dried beads continued to elute the antibiotics for 12 months, whereas the wet beads that was stored in phosphate buffered saline were completely depleted of antibiotics after 6 weeks. This search and this research outcome has enabled us to implant the stored ceftriaxone impregnated polymethametacrylate antibiotic bead into the debrided bone cavities when operating on open fractures in the dead of the night, most commonly on Okada riders with open long bone fractures who do present as unknown and often with financial standing. Mr. Vice Chancellor, in a relay race, 4 agile athletes are expected to play by the rules of staying in their lanes and most importantly exchange their battles at the designated site referred to as the 20-meter space marked with colored arrows called the passing zone. In choosing the relay team for an athletic competition, the first leg is key to a successful competition because if he or she stumbles or drops the bat before reaching the passing zone, no matter how fast the other teammates are, the race is over. As long as the baton is handed over from one leg to the other within the approved zone and lane, the completion of the race is assured, irrespective of the speed, like Usain Bolt, at which this is achieved. But this actually is the story of osteomyelitis, in that the progression from acute to chronic can be very rapid with virulent microorganisms, and it can be rather slow, but equally harmful with docile microorganisms like tuberculosis. I reluctantly joined the League of Surgeons engaged in damage control measures when the last leg of the Quartet races to the finish line and is crowned with osteomyelitis. In addition, there is the unpredictability of the location of the cloaca through which the pus egresses from the affected bone. The start of pus through the skin to a visible location relieves the bone pain and makes access to surgery even easier. However, in some instances, the pus discharges into the synovial joint in locations where the metaphysis of the bone is intractable. The two commonest locations, anatomic locations, are the hip joint, where the proximal femur is within the joint, and also the distal femur, where the distal femoral metaphysis is within the knee joint. These two synovial joints have a peculiarity of note. In my past 15 years practice, I have come across only 2 cases of septic arthritis of the knee joints, again in 2 young adult patients with sickle cell anemia, treated by continuous aspiration and needle washout of the knee joint on account of persistence of symptoms of reaccumulation of pus after each washout. It turned out that in these 2 patients, they had the cloaca opening in the supracondylar region and into the knee joint, but these were not detected by the managing surgeons until they were referred to me. In these 2 patients, the articular cartilage of the femoral condyle and the tibial plate were debrided, suturized, and the distal femoral condyles were carried out, suturation of the distal femoral condyle was carried out, and the dead space was packed with ceftriaxone polymethyl bead with excellent results. These two patients are now destined to undergo total knee arthroplasty in the future because of extensive damage to the articular cartilage due to the presence of pus. Mr. Vice Chancellor, the articular cartilage of the synovial joint is the delicate covering of the ends of the bones constituting the synovial joint, and it is the part of the cartilage anarch that is not stained toluidinely. This unique tissue, which is the main structure of the synovial joint, is susceptible to severe damage when it is exposed to pus, and the damage is irreversible if the pus is not drained within hours. The macrophages and enzymatic activity of the pus cause damage to the superficial layer of the articular cartilage, thereby altering the protoglycan component and the dynamics of water exchange when the articular cartilage is compressed. The chondrocyte of the articular cartilage produces hyaluronic acid. The hyaluronic acid is actually the template upon which the protoglycans are attached using a link protein. And because of the negative charges of water and the protoglycan, they help to maintain the integrity of articular cartilage following compression. But if this integrity is lost, the articular cartilage will continue to become damaged. This damage to the superficial layer, when propagated into the deep layer, results in the loss of tensile strength and elasticity, and the cartilage mantle becomes distorted because the collagen fibers break away. This leads to an increase in the inhibition potential of the articular cartilage, flaking of the articular cartilage loss, osteophyte formation as a response to articular cartilage defect, and the end result is secondary osteoarthritis, with attendant challenges of pain, joint stiffness, limitation in mobility, and deformities. Mr. Vice Chancellor, I was awarded the first British Association for Surgery of the Knee Johnson & Johnson Knee Fellow in 1977. And subsequently, I was awarded the Leicestershire Johnson & Johnson Knee Fellow in 1998. My research activities on the suitability of periarticular osteophytes in the management of articular cartilage defects that I mentioned earlier following pus in the joint was my research work for a Doctor of Medicine at the University of Leicester in the United Kingdom. This back-to-back fellowship offered me the avenue to evaluate the molecular characteristic of periarticular osteophyte using immunocytochemical techniques in the management of articular cartilage defect. The similarities between the chondrocyte of articular cartilage and the periarticular osteophyte in monolayer culture and their collagen content, among others, led me to hypothesize the etiopathogenesis of the periarticular osteophyte using the scanning electron microscope, a hypothesis which has undoubtedly opened a new vista in the study of articular cartilage defect and articular cartilage repair. The cartilage of osteophyte was continuous with that of the normal cartilage when you take a section at the cartilage osteophyte junction, and this is what is demonstrated with arrows in the slide that is shown. With the debilitating effect of osteomyelitis, therefore, and the disability associated with the resultant secondary osteoarthritis of the large joints in this patient with sickle cell anemia, there is therefore the need for Temitope Alonge, the doctor, and later Temitope Alonge, the surgeon, to take cognizance of the challenges ahead and then refocus. Bone infarction or bone infection. Why bother? Mr. Vice Chancellor, early recognition or early diagnosis of acute osteomyelitis in patients with sickle cell anemia is crucial, although this is a daunting task and the diagnostic apparatus in our plan do not give room for maneuvering. This is because the clinical features and early laboratory findings in acute bone pain crisis in sickle cell anemia closely mimics those of acute osteomyelitis and other febrile tropical conditions. Most of, Mr. Vice Chancellor, the pain is an unpleasant stimulus, and proprioceptive pain is even far more common for our clients who come to the hospital. This is because the pain may be a pointer to a disease process, it may be a pointer to a worsening disease, it may also be a pointer, strangely, to recovery from some diseases. The role of pain in the symptoms of disease processes, post-operative recovery, and as indicators of recurrences of diseases, in some instances explains why Oniawa
Alonge et al. In 2017 proposed the adoption of pain assessment as a fifth vital sign in routine patient evaluation outside of the conventional temperature, pulse, respiration, and blood pressure measurement. Most often, pain in the bone is presumed to arise from two sources, from the nerve endings in the blood vessels and from the periosteum. However, since not all pains are superficial, or not all bones are superficial enough to be palpable, and noting the fact that the line of management of bone pain is dependent on the positive organism, accurate localization of the origin of pain is mandatory. Patients with sickle cell anemia and other hemoglobinopathy, commonly referred to as sickles, will have varied episodes of bone pain in their lifetime, and the management will be different on each occasion. This has probably informed the protocol of care for patients living with sickle cell anemia. In our environment, these patients are presumed to have acute bone marrow infection or osteomyelitis, until proven otherwise, and they are therefore commenced on high-dose broad-spectrum antibiotics as a first line of management. However, what is worrisome is that the managing clinician may terminate the use of these antibiotics if the suspicion of acute osteomyelitis is actually ruled out. This, in turn, may lead to antibiotic resistance with their consequences. Mr. Vice Chancellor, first, I initiated the isolation of offending organisms by direct bone aspiration. My research interest was further broadened with an International Atomic Energy Agency grant in 2005 for a 3-month stay in nuclear medicine department at the Kasserine Hospital in Cairo. At the end of my 3 months confinement in Cairo, attending to over 50 patients with bone pain, having bone scintigraphy, I was not convinced that this was going to give me a conclusive answer. However, it was apparent that this investigation could not be routine because it is expensive in our environment. In addition, the commonest foci of acute osteomyelitis are in the metaphysis of the long bones, and this is adjacent to the growth plate, which on routine bone scan itself may show evidences of increased uptake even without a bone infection. Still unable to convince myself of the most efficient and affordable method of making an early diagnosis of acute bacterial osteomyelitis because of the effect on both the joint of the patient and the patient itself, I was awarded the University of Ibadan MacArthur grant to carry out more research on bone pain at the Medical Research Council of Great Britain in the Gambia. My training on polymerase chain reaction for the identification of bacterial DNA was not convincing enough, even with real-time PCR technique. The interaction between the researchers at MRC was usually very, very exciting. Apart from our normal volleyball competition in the evening, we also had periods of exchange of ideas. The various weekly seminars, presentation at the MRC provided an enabling environment for researchers to interact. And it was during one of these sessions that a colleague of mine from Pakistan suggested that I consider investigating a chemokine that his team had isolated in previous research activities, which was expressed in the presence of significant bone tissue destruction. My seminar presentation zeroed in on the evaluation of the serum level of monocyte chemoattractant protein 1, MCP1, in short, as a marker for acute osteomyelitis. It was received with great applause, but it was actually a discovery done 48 hours before. In 2010, I was awarded the University of Ibadan alumni grant to study the role of MCP1 in differentiating bone pain in patients with sickle cell anemia, that is, differentiating acute osteomyelitis from acute bone infarction. This was premised on the findings of Ian Marriott and his colleagues who had earlier demonstrated that bone-forming osteoblasts secrete immune mediators when exposed to Staphylococcus aureus infection in vitro. Their efforts paid off in 2005 when they were able to demonstrate the same protein I was looking for, MCP1, in the presence of Staph aureus infection in the bone. Mr. Vice Chancellor, this finding is aimed at arresting the first leg of the Quartet of osteomyelitis, the topic of my novel, to avoid the devastating consequences of this dreaded disease whose diagnosis continues to elude a simple man. I took a detour from the norm of managing acute osteomyelitis and chronic osteomyelitis the way it was routinely done. I set up a research team with Dr. Tita Akinbola at the Department of Hematology and Mr. Najim Fashin, Mr. Andrew Adegoke, Mr. Tobilo Balala, and Mr. Toko Gunay, all medical lab scientists at the University College of Ibadan, with the singular priority of addressing the challenges of acute bone pain in patients with sickle cell anemia in our environment. We came up with a comprehensive evaluation protocol that includes blood culture using the BACTEC machine, assay of the serum MCP1 value, and staining of the blood films for toxic neutrophils for different states, among other measurements. This research aims at using a confluence of parameters as opposed to absolute values of MCP1 as clear indicators of acute bacterial stomatitis presenting as bone pain. Mr. Vice Chancellor, sir, our findings shows that 50% of our patients evaluated had a significant rise in the MCP1 value on day 2 assessment. Compared to normal values reported by the Stanislas cohort, our day 2 titer values were twice to 20-fold higher than normal. We believe that the skewing of this figure will be due to the late presentation, and this is a challenge in our environment, and this makes the interpretation a little bit difficult. However, our preliminary evaluation also shows that the May-Grover Jimsa stay, when compared with Leishman, Fields, and Wright, was the best in assessment of toxic granulation in nutrients. We thereby propose a scoring system of 11 parameters, MCP1 value inclusive, as you can see on the table that is shown. Mr. Vice Chancellor, sir, because of the miserable state of patients with chronic osteomyelitis, I was compelled to join the team to provide damage control at the intervention of chronic osteomyelitis since 1995. In my quest not to be just a doctor, according to Professor Hussain, and not just one of the surgeons, I have moved the management of osteomyelitis from mere socialization and curettage and best guess antibiotics to the formulation of the ceftriaxone polymethametaculate bead. I've also gone ahead to look for targeted treatment options because most of the organisms were sensitive to this particular antibiotic. I veered off into suggesting an alternate source of chondrocyte for periarticular osteophytes in the management of articular cartilage damage, which can come when you have post-hooking to the joint. I have demonstrated the remarkable tensile strength of periarticular osteophytes, which makes it a suitable substitute for osteochondrial graft using the osteoplasty. Mr. Vice Chancellor, my Ebenezer, I commence the isolation of affected microorganisms and osteomyelitis of superficial bones. I isolated the offending microorganisms in chronic osteomyelitis and ascertained the antibiotic sensitivity pattern to counter best guess antibiotic use. I formulated the ceftriaxone polymethametaculate antibiotic bead as a targeted bead for the management of chronic osteomyelitis, and this is the first report in the literature globally. 30 gentamicin polymethametaculate bead, Septopal, utilized by just one patient, cost £50. But 80 ceftriaxone polymethametaculate antibiotic bead cost only £75, and it is shared between 3 to 4 patients. And this bead, that is the ceftriaxone PMMA bead formulation, is even more appropriate in our client. I have demonstrated that dry ceftriaxone PMMA bead continues to elute ceftriaxone with a minimum shelf life of 12 months. I've designed and produced the Alonge intraoperative antibiotic bead maker as a point of technique. I've gone ahead to demonstrate the suitability of the periarticular osteophyte in the management of articular cartilage defect. This submission for my doctorate thesis happens to be the 21st contribution in the literature since 1874 as a method of repairing articular cartilage defect. I've also gone ahead to demonstrate that the expression of MCP1 in acute osteomyelitis is real, and I propose a scoring system aimed at halting the first leg of the quartet of osteomyelitis. Thus far, as the Lord helped me. Mr. Vice Chancellor, armed with this piece of information, the first leg of the quartet has received the red card and the race is over. Armed with this information, the veil over bone pain can now be removed and a definite diagnosis can be reached before irreversible damage to the bone comes to bear. The veil has finally been removed, and we can see through and differentiate bone pain in people with sickle cell anemia. Proverbs chapter 16 verse 3 reads, "We can make our plans, which I did at the age of 10, but the Lord gives the right answer upon the age of 59." Proverbs 16 verse 3 says, commit your plans unto the Lord, and your plans will succeed. The partnership between me and my efforts and my God, who took control, has been fruitful in this past 15 years. I give all the glory and honor to him because he is a mighty God. I thank my late father, Chief Jeremiah Alonge, and my late mother, Dr. Inaugural, who labored so hard to see me through education. And my late mother actually attended adult education classes when she was carrying my pregnancy. And I also attended the same classes before I got to the University of Ibadan as a lab attendant in the university. I thank my stepmother and my siblings on both sides. But I lost my mother almost 2 decades ago. I've had the support and prayers of other mothers. My second mother, Reverend Mrs. Ajoke Oluwaleyimo, who has always had me on her mind since I proposed and actually went ahead to marry her daughter, Temitope. I appreciate her prayers, counseling, her love and affection. I'm indebted to Professor Latif Akoni Hussein, who picked me up from the age of 17 and has nurtured me to adulthood. The Lord bless you. I'm also so grateful. He named his son that was born when he knew me, Temitope, and who happens to be a doctor today. I'm grateful to the late Professor David G. Montefiore, who took me up from where Professor Jose had left. He took me to England. I met him with the Lemons Grove, and he saw me through all my terrain and struggles. Dad, even though you are gone, I love you with all of my heart. My gratitude goes to Professor Quartet, who stood up for me and enrolled me into residency training program in surgery, and he still believes in me 30 years after. I'm grateful to Professor Jide Ajayi, whose affection for me began in 1983 when I was his house officer. He looks much older than this. He was the chief medical director when I was a resident doctor. He approved my appointment on the grounds that he believed Professor Adekunle's story, that I would do well. I am so grateful to Professor Oji Adao, who had his position on the line to support my residency training in the United Kingdom under the Overseas Doctors Training Scheme. Your quote remains in my mind. When I see some of you and I'm about to die, when I see some of you, I know I will live. But when I see some of you and I'm about to die, I will pick up and sign my death certificate myself. I want to thank the support of my very beloved teacher, but who is my secret admirer, and I admire his efforts, Professor Temitope Shoko. He stood his ground as the provost of the College of Medicine and insisted that I must go and develop my academic career. He signed me up for my doctorate degree. Uncle T, I'm very grateful to you. I thank my academic and professional parents, Emeritus Professor Ogulesi, whose quiet meaning and counsel has seen me through thus far. Daddy, I'm very grateful. Sadly, but honestly, I have come to accept the fact that there are no friends among equals. But some of my friends and colleagues have been supportive and they have defied this seeming reality of everyday life. I'm deeply indebted to Professor Itope Okumbodede, the Vice Chancellor of the University of Ife, who has been my mentor since 1974, and on whose instruction I'm giving this inaugural today. I appreciate the support of my friends, Professors John Aneto and Professor Oluwabumiola Kwadeola. This was our graduation at the University of Leicester in year 2000. I call them into academic guidance. I appreciate the members of the three Crusaders for Academic Justice and Equity, Professor Bio Taiwo and Professor Shegun Ademowo. These are my true friends, Professor Basilo Kayalam, Professor of Cardiology, and Mr. Moyo Ayeye, a seasoned geologist who has continued to support me even as the Chief Executive of UCH. I'm indeed very grateful to my Parent Association, MDCAN, for standing by me. I'm grateful to ASU, I'm grateful to SANU, SSA, NASU, for allowing this inaugural to take up and go on despite the NSC strike. I'm grateful to the Association of Resident Doctors, Noah, Magu, and the entire research family. I thank my research team, Dr. Tita Kimbola, and all the members of the team. I also thank Dr. Iduwayede, Dr. Victor Akimoladu, Adibi, most valuable, and most importantly, the man in the IT, Mr. Peter Oshio. I thank my senior pastor, Pastor Alex Adibi, whose ministry, the Water Life Ministry, has provided me the spiritual platform that has continued to support me in its entirety. I thank my old friend, late Pastor James, who has gone to be with the Lord. But I thank his wife, now my resident pastor, Pastor Dr. Rinka Ademi, who has not left me, but has continued to uphold and pray for me in all of my challenges. I thank the executive governor of my state, Ondo State, Arakuni Rotimi Akeredolu, for assisting and coming for the Inaugural, and the deputy governor of Oyo State, Chief Alaki Adeyemo. I thank my father from the city of the King, Oyo, Prince Afonja. I thank my friend, Mr. Victor Chogo, who has taken time to come from his busy schedule from Lagos. I thank my devoted and dedicated staff who have shielded me from various evils. Please forgive them if you're not allowed to see me often. They've kept the faith, and I thank my siblings on both sides of the divide. God, in his infinite mercies, has blessed my wife and I with 3 wonderful children. Oluwa Damiloju, Iyanu Oluwa, this is Iyanu Oluwa Damilola, and Iyanu Oluwa Funke. They were denied so many pleasures while they were growing up, so that Daddy could save enough money for his conferences outside of Nigeria. They have been caring and an understanding team, and my prayer has and will always be that the good Lord will preserve your lives and endow you with divine godly wisdom such that you will surpass me and surpass my modest achievement in your lifetime. I thank the Honorable Minister of State for Health, Dr. Iranere, ably represented here today by my friend and colleague, Dr. Mustafa Alimi, the Medical Director of National Orthopedic Hospital, Igobi. I thank you, sir, for coming. I thank my duo of inestimable value, Temitope Adini, Uluwatoyi, who sacrificed our own career as a broadcaster. She sacrificed her comfort to support me as I climbed the academic ladder. You have given me so much peace and home front. By making research and clinical services plausible and possible, you have serviced the altar of prayer with tears and groaning that has attracted the attention of our good Father. Temitope, thank you does not seem strong enough to express my gratitude to you. I want you to know, and I declare publicly, that I will always love you. Thank you for all.
may stand. Inaugural, I've gone to greet the fourth professor of medicine in Africa and medical professor Theophilus Okolisi. Pastor Mrs. Adeyemi, Pastor Mrs. Oyajima, Pastor Professor Aminjide Oyeyinka, Mrs. Sheuda Washaju, one of the Vice Chancellor, Bishop Inaugural University, and indeed I must recognize you to back out OON as the chairman of Safari.